next is ruptured hepatocellular carcinoma. It's V9. And a 68-year-old man presents to the ED with sudden onset of abdominal pain and distension. He is noted to be pale with a systolic blood pressure of 90 millimeters of mercury, and the abdomen is distended and tender. How would you manage this patient? This is an urgent situation. I will approach the patient with CRISP protocol. After checking airway, start oxygen, IV fluids, and monitoring, and then it looks like he has intra-abdominal bleed, and I am worried about either ruptured abdominal aneurysm or ruptured hepatocellular carcinoma. And then I will do a bedside ultrasound scan that will distinguish between the aneurysm and the rupture. The imaging management plan is fluid cessation with a plan of permissive hypotension to avoid worsening of the bleed. Once hemodynamically stable, the appropriate confirmatory test is the abdominal CT scan to see the primary lesion, the extent of bleed, and the ongoing bleed. The CT shows a 7 cm lesion in the segment 6 of the liver, and there is evidence of contrast extravasation. There is also high density free fluid in the Morrison pouch and extending down to the right peripheral gutter. What would be needed for this patient? There is a need for an urgent angioembolization to secure control of the ongoing bleeding. In addition to replacement of the blood product, there is also need to assess for coagulopathy, as may be associated with the HCC and cirrhosis liver, which patient might need the FFPs or platelets. Intravenous broad-spectrum antibiotics are required prophylactically in view of the intraperitoneal blood and expected necrosis after angioembolization. Adequate appropriate analgesics. After resuscitation and angioembolization, the patient stabilized. What would be the definitive management options? There are two main areas to be addressed. One is the HCC that should be dealt according to the MDT, and after looking at the criteria for liver tumor surgery. And other is the intraperitoneal bleed that needs to be drained by the radiological drain or on the time of the surgery when you are resecting a tumor. Thank you.